Good morning, thank you, and thank you to the organisers. It's my first time here, so it's a privilege to be speaking to you today. What I've been asked to do is to make some comments about the complexity of exacerbations of respiratory symptoms, a slightly convoluted title, which I think encompasses two major things. I'd like to spend a little bit of time talking about what I think is, and importantly, what I think is not an exacerbation of COPD. And then secondly, I'd like to address the field which is moving quite rapidly at the moment, the idea that all exacerbations are not the same, that in the same way that we can phenotype patients in the baseline state, we can also phenotype patients at exacerbation. So let's start with the first of those. Let's look at what is and what isn't an exacerbation of COPD. And I'm going to start by going back to the gold definition. So the 2011 definition is there for you on the screen. As with the comorbidities that Klaus has just been talking about, exacerbations now also make it into the very definition of the disease, suggesting that there's something important about these events. But what are they? How are we going to define them? The first thing to say then is that we all recognize an exacerbation when we see one. Here's one of my patients from London. Her presentation has been sufficiently severe that she's needed to be admitted to hospital on this occasion. Her lips are blue, she's wearing supplemental oxygen, she's seen a touch too much steroids over the years. We recognize these events when we see them. And patients are cycling between stable disease and exacerbation at different frequencies between individual patients and at different frequencies as their disease changes. And that's been shown very nicely in this work more recently by Sami Suisa, suggesting that as COPD progresses, the tempo, the rate, there's an acceleration of exacerbation events. The time between successive exacerbations becomes shorter and shorter and shorter as COPD progresses. So we have an idea then about the natural history of these things that we're dealing with. The Gold Committee have also now defined an exacerbation. Here's the Gold definition. So it talks about an event occurring in someone with COPD that's primarily about a change in a patient's symptoms. That symptom change is beyond the day-to-day variation that our patients experience, so something that's worse than that. And it's acute in onset. It's not something that's slowly progressive that might reflect disease progression. It's a more sudden change. And it may warrant a change in treatment. So that's a helpful start, a useful definition. But one of the problems with this is, in fact, there are two definitions hiding within this one definition. And the first of those definitions is a symptom-based definition. So you could say that an exacerbation is a change in a patient's symptoms. An alternative way of defining exacerbations would be to use the treatment approach. And that's the second definition that's hiding within here. So any event which warrants a change in patient's therapy could be called an exacerbation. So within that gold single definition, we have two different approaches. This is how it works. So for a symptom-based criteria, a patient feels unwell. They then may or may not record it on a diary somehow, ExactPro, for example. And if that symptom change crosses a predefined threshold, then that event is an exacerbation. That's what a symptom-based definition looks like when you think about it logically from step to step. Note that there's no need for treatment in there. So if a patient doesn't get treatment for that exacerbation, they still might be having an exacerbation. Healthcare utilization is different. It starts in the same place. A patient still feels unwell. They notice a change in their symptoms. But here's something different has to happen. That patient has to access healthcare, and a healthcare professional has to say, yes, I see you, I assess you, and yes, this is an exacerbation. And only if that healthcare professional says that event is an exacerbation is it defined as one. And we can think about a number of different problems with that. But if we look at the two side by side, then there are advantages and disadvantages of using those two definitions in clinical trials. Symptom-based definitions, because of the need to record on diaries, are more expensive. Having said that, though, because they collect all events, not just the ones which are treated, then they collect many more events, and that might be beneficial if you're running a clinical trial. It's also independent of other factors, because you might imagine for a healthcare utilization, a treatment-based definition, that if the patient isn't able to access healthcare, for example, because of financial reasons or travel problems, then they cannot, by that definition, have a healthcare utilization exacerbation. HCU, however, are easier to collect and may be considered more robust. So there are balances, and we have to take this into account when we're comparing data from across clinical trials. There's a third definition, though, and that's a definition that we use day to day in clinical practice. Because for me, when I'm on the clinical service, an exacerbation is a clinical diagnosis. It's a clinical diagnosis of exclusion, and we don't have a diagnostic test. Let me tell you a little bit about what I mean about that. So it starts with symptoms, of course it does. And actually, if you look at lung function and physiology, you can show changes in lung function, even in relatively mild community-treated exacerbations. So what's plotted on the graph here is peak flow as a easy marker of lung function, expressed as a percentage of each patient at baseline. And this, if you like, is a map of what's happening during a typical community-treated exacerbation. And these data come from over 500 exacerbations, and if you do that, you can show quite nicely a statistically significant fall in peak flow at the start of an exacerbation, which tends to get back towards normal over about a course of a month, which is fine. That's all very interesting, until you look at the scale here, because we're talking about percent. So the changes here at an individual patient level are far too small to be able to be detected, let alone to be clinically meaningful. So there are changes in physiology at exacerbation, but because these changes are small and because the tests are difficult to do in breathless patients, we're still left with a symptom-based definition primarily. The other approach will be to look for a biomarker, to look for an inflammatory biomarker that can differentiate stable state from exacerbation of COPD. And when we published this work back in 2006, this was the largest study of its kind at the time. And we looked at 36 different markers in the blood. In this case, you could also choose to look in sputum, of course, but these are blood biomarkers. And you can show significant increases in various markers between the baseline state and exacerbation onset. Things that you might expect, like CRP and a whole host of other things. But the question then becomes whether that's useful. Can you actually differentiate stable disease from exacerbation by doing that? And the answer is no. When you plot receiver operating characteristic curves to look at the ability of CRP to differentiate stable disease from exacerbation, the answer is it's neither sufficiently sensitive nor specific to be able to do that. So to give you some numbers, if you choose a cutoff which is 90% sensitive, you're picking up 90% of the exacerbations, you'd need a cutoff CRP of about 2 to do that, but the specificity is terrible, just 29%. Whereas if you want a much more specific cutoff, so you go for a CRP somewhere around 28, then that's giving you different information, you have a highly specific marker, but it's very insensitive. So there is and remains no respiratory troponin. We do not have a biomarker that can reliably differentiate stable disease from exacerbation. And that's a clinical problem. So we're left with 4 different exacerbation definitions. We have 2 definitions which are encompassed within the guideline definition that are used in clinical trials, healthcare utilization and symptom-based. And then we have the definition which we're all using in clinical practice, based on it being a clinical diagnosis of exclusion. Let me show you how that runs into problems. This is the X-ray of a 64-year-old chap who presented to our service recently. He does have COPD, and he had worsening breathlessness. That breathlessness was associated with cough and also with left-sided chest pain. And the question is this an exacerbation? That's what the junior staff are trying to establish when they're seeing this guy in the emergency room. And you can see, hopefully, I've arrowed it, that in fact this guy has a pneumothorax. So in terms of a symptom-based definition, has this guy had a change in symptoms? Well, yes, he has. So that does meet a symptom-based definition of exacerbation. But do I think that that is a real-life exacerbation of COPD? Well, the answer to that is no, I don't. I think that's a guy who has COPD who's had a pneumothorax. And then the healthcare utilization definition is more complex, because if he was seen and treated with antibiotics and steroids incorrectly, then he would have had a healthcare utilization definition exacerbation. But if he'd had an X-ray, as in fact happened, then clearly he doesn't, because it's a pneumothorax. So these definitions are imperfect. It's even more complicated when you have someone presenting with this sort of X-ray. So a female patient in this case, again, worsening breathlessness and cough and right-sided chest pain, and you can see that she has a right lower lobe pneumonia. But the same things apply. By a symptom-based definition, she does have an exacerbation. Real life, probably not, although there is an overlap here. I think this is pneumonia in someone with COPD, not a simple exacerbation of COPD. And again, healthcare utilization definition would depend crucially on the presence of an X-ray. So I'm going to ask you not to share the next thing I say, but you could argue that in fact the gold definition isn't really fit for purpose. Certainly don't tell anybody that from the committee who might be walking in. So my key message for the first part of this presentation is that not all changes in symptoms in a patient with COPD represents exacerbations of COPD. There are lots of conditions that patients with COPD can develop which can mimic or can complicate exacerbations, pneumothorax, pneumonia, PE, heart failure, which you have to think about, consider and exclude, because the bottom line still is that exacerbation of COPD is a clinical diagnosis of exclusion. So the second thing I want to consider is the concept that not all exacerbations are the same. We are used to starting to think about phenotyping our patients, but what about phenotyping exacerbations? Is that something that we should be doing? Is that something that's helpful? The phenotype story starts with the idea that there's complexity in COPD. And I like this figure very much. We have lung function here on the x-axis, and we have SGRQ, so health status, on the y-axis. And there's a statistically significant relationship between the two because there are lots of points here. But for me, this is just a scattergram. So you have patients in red, for example, who have relatively well preserved lung function, who have a major impact in their life from their respiratory health status, compared to patients in green whose lung function impairment is much more severe, but with a lower SGRQ score appear to have a much lower impact on their health. So as we've been hearing in the previous presentation, not all COPD patients are the same. And this really isn't new. We're used to thinking about people with an emphysema predominant phenotype, with a chronic bronchitic phenotype, but we've just changed the terminology for that more recently, and we're calling this process phenotyping. If you go away and look up the definition of a phenotype, and this is the sort of definition that comes up on Wikipedia, it describes a phenotype as an observable trait, something that results from gene, environment or gene-environment interaction. But when it's applied to COPD, what we really mean by that is it's a feature of the disease that is either predicting an outcome or is predicting a treatment response. And importantly, that is something which needs to be stable over time. There are lots of different ways of phenotyping patients with COPD. You could take clinical phenotypes such as chronic bronchitis or exacerbations, comorbidities. You could take inflammatory phenotypes, radiological phenotypes, emphysema, small airway obstruction, genetic alpha-1, and they may overlap. So you might have an alpha-1 deficient, emphysema predominant, frequent decliner. They're not exclusive. But each one is telling us something about the complexity of disease, and the way that those phenotypes cluster together, as we've heard, is not a random event. I think certainly one of the most important phenotypes would be that phenotype of patients who are predisposed to frequent exacerbations. And we know a lot about these people. You can quote data, for example, that shows the more exacerbations you have, the greater the impact on your health status. So top left on the figure. Bottom left, one example of a number of studies, but the more exacerbations you have, the faster your lung function declines. The effect is not large, but it's there. And top right, you could think about mortality. The more exacerbations you have, the more likely you are to die. And for all those reasons, they're associated with increased costs, personal cost to the patient, but financial cost to health services and to payers. So this concept that frequent exacerbations is a phenotype, relation to exacerbations is important. It's generally true that as your COPD gets more severe, so as you move from gold 2 on the left through gold 3 to gold 4, that you are more likely to become a frequent exacerbator. Frequent exacerbations here defined as 2 or more treated events in a year. So if you are in gold 4 in this data, which was from Eclipse, then about half the patients would fulfill the definition of being a frequent exacerbator. But if you look back at gold 2, still 1 in 5 of those patients, 22%, would fulfill the definition of frequent exacerbations, and that may mean that some of our milder patients, in terms of airflow obstruction, are being undertreated in terms of the activity of their disease, and it may mean, in fact, that some of our more severe patients who are resistant to exacerbations are receiving interventions that they don't need. Importantly, this phenotype does seem to be stable over time. Eclipse was a 3-year study, and what the figure shows is patients in year 1 divided into 0, 1, and 2 exacerbations. And then what we've done here is we've taken the group with 2 exacerbations in year 1 forward to year 2, where about 60% of them will continue to have 2. And if you take this group forward to year 3, then the figure's over 70. In other words, if you had frequent exacerbations in 2012 and frequent exacerbations in 2013, there's about a 70% chance that you're going to have frequent exacerbations in 2014 as well. So this is a relatively stable phenotype. And that's important because it enables us to do something important in clinical practice. It enables us to identify these patients by asking a very simple question. How many courses of antibiotics and steroids did you need for your chest in the last year? And in patients who are answering 2 or more to that question in 2 or more years, then we are able to target them for the effective exacerbation reduction interventions that we have available. When it comes to treatment of exacerbation, though, treatment of exacerbation has lagged a long way behind our ability to prevent exacerbations. There's been much less effort put into this. And this is a model, if you like, of how we treat exacerbations today in 2014. It would have looked very similar in 1974. Nothing has changed. We make an assessment about the severity of the presentation. For the mildest exacerbations, we may just treat with increase in bronchodilators. For exacerbations not responding to that, we may add in corticosteroids. Antibiotics when there's been a change in sputum, and various other add-on therapies that we can use after that. There's nothing new here. Is the first thing that's important. And the second thing important is that we're treating exacerbations all the same, as if there are no differences between them. And I really want to challenge that, because I think there are differences between exacerbation. The first thing relates to this concept of exacerbation severity. Exacerbation severity is really a composite of the severity of the patient's underlying disease and the severity of the insult. So if you take an arbitrary measure, respiratory failure, for example, someone needing ventilation on the ICU, then that patient may have got there in 2 different ways. It may be that they have milder COPD but have suffered an overwhelming insult. The alternative, of course, is that their underlying COPD was much more severe, and the insult in addition was much more trivial. So exacerbation severity is a useful concept, but I do think we need to think of it as a composite, both of the severity of disease and of the severity of the insult. There's another way, though, that we can think about looking at different sorts of exacerbation. This is quite interesting work which has come out of Chris Breitling's group recently in Leicester. And they've been looking at different exacerbations clinically, which is something I think we're used to doing. Thinking about exacerbations associated with sputum production, for example. Thinking about exacerbations which have more of a viral flavour, upper respiratory tract symptoms present. But what they've done in addition to that in this analysis is they've done a large look at blood and sputum inflammatory markers and conducted a principal component analysis to really try and pin down the key differences between different sorts of exacerbations. And they were able to identify 4 different clusters of exacerbations based on different patterns of cytokines, which you can appreciate conceptually by drawing a sort of 3D graph which has a Th1 axis pointing towards you, a Th2 axis pointing up the screen, and a pro-inflammatory bacterial kind of flavour exacerbation coming out towards me over to the left of the stage. And interestingly, there are overlaps between this principal component analysis and the clinical phenotypes. So if you had a bacterial type exacerbation, lots of sputum, lots of phlegm, you tended to have an inflammatory phenotype which appeared in the blue here. And the best marker of that was by looking at sputum interleukin-1 beta. If you had a virus exacerbation, so the sorts of exacerbations where viruses were commonly isolated, clinically that meant you often had upper airway symptoms, rhinitis, sore throat, then you tended to be in the red sphere in terms of the inflammatory phenotype, more down a Th1 axis bias in your cytokines. And the best marker for identifying that was a blood marker called IP10. The third sort, in green, is a proportion of exacerbations which appear to be associated with a relatively elevated level of both blood and sputum eosinophils. This provided a distinct phenotype, the best marker being a blood eosinophil count, unremarkably. And then there's a smaller group of exacerbations which are appearing in the grey, which Breitling and his colleagues call pulsy inflammatory, where there didn't seem to be much change in inflammation during these events. So certainly if we take a principal component analysis look by examining a whole range of different exacerbations, blood and sputum inflammatory markers, we can divide them into different characteristic patterns which overlap with different clinical patterns, suggesting that there really are differences in exacerbation. I think that's important because it means that we may be able to treat these groups in different ways. The final point here is that the sorts of exacerbations you get is not random. So the sort of exacerbation you're likely to get, the phenotype of your exacerbation if you like, is dependent on what phenotype of COPD you have in the first place. So if you are a chronic bronchitic type patient, then perhaps it's not that unsurprising to think that actually most of your exacerbations are the bacteria predominant, sputum interleukin-1b pro-inflammatory type model. Whereas if you're one of the patients who tends to get exacerbations associated with a peripheral eosinophil count that's at the upper range, then actually that reflects you in the stable state too. A proportion of patients with COPD appear to have higher sputum eosinophils. So there are different types of exacerbations, and that's important for treatment, or at least it might be. And you can predict what sort of exacerbation your patient is likely to get by looking at what they're like in the baseline state. So if I tie all that together, my two key messages really are to think about what is and what isn't an exacerbation of COPD, because certainly it's true that not all changes in symptoms in someone who has COPD is an exacerbation of their COPD. And that reflects our inability to diagnose these events in a reliable way. It remains a clinical diagnosis of exclusion. And the second message I want to share with you is that exacerbations are not all the same. There are different phenotypes of exacerbations, and actually you can start to predict what type of exacerbation patients are having by looking at the phenotype of the patient in the baseline state. It's been a pleasure to be invited to speak to you today. Thank you for your attention.
We have time for two questions.
I would like to ask you just something. I fully agree with your headline or key message. COPD exacerbation is a clinical diagnosis of exclusion. But you put a lot of emphasis on chest X-ray, but you didn't discuss something which is, I think, clinical practice, at least not in general practice, but in the hospital-based practice, the biomarkers of like D-dimer, pro-BNP, cardiac enzymes, you know. So do you think we should change the definition, introduce these, at least in some healthcare utilization?
So you raise a really important question, and it really comes down to what is significant overlap between the talk that Klaus gave and the talk that I gave. And that these comorbidities, this multimorbidity that Klaus has been talking about, may affect the presentation of exacerbations. We know, for example, that even community-treated exacerbations are associated with increased cardiovascular risk, which persists, and Klaus showed BNP data that shows where your BNP is elevated at exacerbation, that affects your prognosis. So I think there are a couple of reasons to think about those biomarkers that you're suggesting, so cardiac biomarkers like troponin and BNP, and then markers like D-dimer. One is to use those to help us to exclude another primary cause for a patient's deterioration in symptoms. So, for example, to think about pulmonary embolus, or whether in fact this really is a deterioration in cardiac failure rather than exacerbation of COPD. So that's one reason to use those markers. But the other reason to use is even when we think that this is a bona fide exacerbation of COPD, we now know that that is itself associated with a period of increased vascular risk, and actually measuring, thinking about, modifying our approach based on those biomarkers may actually with time improve outcomes too. So I think for both those reasons it's important.
Thank you. Another question?
I'd like you can elucidate something about bronchiectasis. Which is the role of bronchiectasis? I mean, is there the possibility that some patient with bronchiectasis can simulate COPD and following acute exacerbation of COPD?
So that's a really good question as well. And I think the community is just coming to grips with the challenge of patients who present with an overlap. Because of the increased use of CT scanning in patients with COPD, it's now very common to find a degree of airway wall thickening and dilatation that would meet the criteria for bronchiectasis. And similarly, in bronchiectasis, certainly as it's more diffuse or severe, a proportion of those patients will have fixed airflow obstruction, which strictly speaking would meet the definition of COPD. And the ultimate problem here is that bronchiectasis is an anatomical, structural, radiological definition, and COPD is a physiological definition. So because they're coming from different ways, you create this overlap. I would argue that it is important to try and work out what the primary diagnosis is, because the treatment is different. They're a treatment that you certainly might consider in patients with COPD. Inhaled corticosteroids is a good example in terms of their ability to reduce exacerbations, that you certainly would not be considering routinely in bronchiectasis unless the patient had asthma underlying their disease, for example. And the other way around may be true too. And I also think it affects your investigative strategy. A patient presenting de novo with bronchiectasis demands a range of investigations to exclude a primary cause, immunodeficiency, cystic fibrosis, the whole range of things. And actually that may not be appropriate to patients who've got a primary diagnosis of COPD, who've got minor degrees of airway wall thickening. So there is an overlap, and we're just starting to work out actually what that means. But I do think we have a responsibility to our patients to try and dissect that out a little bit so that we can get the care right.
Thank you. Another question?
Paola Rotoli.
Sorry, just a comment and probably
I thought
question.
I got away with it then.
Because it's very interesting, because the definition of acute exacerbation is also a big problem in idiopathic pulmonary fibrosis, in the sense that for us it is a very acute problem and very severe for the patient, because it can drive to death. And in this case, we exclude embolism, heart failure, and respiratory infection. But sometimes it's very difficult exactly to define what is happening to the patient. It drives the therapy, because if it is an infection with antibiotics, and if it is inflammation, you need the immunosuppressant. CT scan sometimes is helpful, but sometimes the patient is so severe that we can do really a CT scan, because they need a lot and lot of oxygen. So I think that it can be something that could be a similar problem. And for instance, my question is, do you think that we can have a sort of scale of things that we have to do just to arrive to a good definition of acute exacerbation? For instance, the need of oxygen, the increased need of oxygen, the possibility to do a CT scan, the possibility to measure other parameters that can help clinician to say what we have in this patient.
So that's a really interesting question. I was at a meeting last week which was divided between COPD and interstitial lung disease. And I was struck at the similarities but also the differences in the way that interstitial lung disease doctors define exacerbations. That's not my field, but my understanding is that if you're an interstitial lung disease doctor, you define an exacerbation of ILD on the absence of any infection. Whereas actually in COPD, we believe that most exacerbations are driven by infection. So although we're both dealing with chronic diseases with intermittent deteriorations of respiratory symptoms, our approach to the definition is very, very different. You guys go to a lot of lengths to exclude infection, and we go to quite a lot of lengths to try and prove that it's there. So that's an interesting difference. My problem with COPD and COPD exacerbations, I guess, is the scale of the problem. And that as a hospital specialist, the patients who get admitted to my service in London either have terribly severe insults or their COPD was so bad that it didn't take very much for them to develop respiratory failure. And expecting the vast majority of exacerbations of COPD, which are managed in primary care and by community services in the UK and more widely, of course, to go through a diagnostic algorithm which involves a chest X-ray and blood tests, let alone a CT scan, I don't think is practical. And I'm not sure that there's evidence that not doing that has really resulted in a great deal of harm. I think ILD is different, the approach is different, and the disease is less prevalent. So many of those exacerbations I know are going to present to the team who look after them.
Just a very short comment, but probably now there is the evidence that there is an initial evidence that could be a respiratory infection also in interstitial lung disease, because they are much more common in winter. When there are viral infections. So probably in some patients these drugs could cross the wall, in some other not. But probably it's the same figure.
Exactly, really interesting overlap.